sekalian jadi co-host. Di mute Bu Ate.
Oke, Pak Samsul, ini sudah ada 42 partisipan. Apakah
Boleh?
akan kita mulai sekarang?
Boleh. Kita mau nyetel film dulu Mas Eko.
Nggak usah Pak, nggak apa-apa.
Oke, ya.
Izin memulai sekarang. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. The Honorable Dean Faculty of Public Health Universitas Diponegoro, Dr. Budiono, SKM, MKes, Head of Master Program, Master of Health Promotion, Universitas Diponegoro, Dr. Andes Syamsul Huda Budi Mustafa, MKes, our today's speaker, Assistant Professor MD Sejahan Miah, PhD, and all of today participant. Good morning, salam sehat dan salam sejahtera untuk kita semua. We would like to welcome you to educational seminar series presented by Master Program of Health Promotion Universitas Diponegoro, Culture and Behavior Related to Maternal and Child Health and the Implication for Health Promotion Strategies on 20th August 2022. Ladies and gentlemen, my name is Rati and I'm going to be the moderator today. But before we begin the main session, I'm sorry that I'd like to inform you the sad news we received today. Our colleague, our sister and friend of today's speaker too, Ani Setiawati, SKM MKes PhD, passed away this very morning, and some of our member and the dean now is heading to Magetan, East Java, to attend the the funeral ceremony. Ms. Wati is the lecturer of Health Promotion Department, Faculty of Public Health Universitas Diponegoro, and she has large contribution to the faculty, especially for master program of health promotion for many years. Ladies and gentlemen, I beg you favor to send a prayer for her together with us for a couple moments. Prayer begin. Over. Thank you so much. May our condolences and prayers bring the comfort and ease the pain for this loss. Well, moving to the next agenda, we will start with the first agenda, which is greeting and opening that will be delivered by Head of Master Program of Health Promotion, Dr. Andes Syamsul Huda Budi Mustafa, MKes. Screen is yours.
Okay. Thank you very much, Ms. Rati. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Best greetings to the Honorable Mr. Budiono as the Dean of the Faculty of Public Health at University of Diponegoro. Although today he did not give his speech at this seminar because he have to takziah, pay tribute to our colleague, Mrs. Ani Setiawati, who passed away early in the morning today. Our lecturers, colleagues, invitees who I cannot mention one by one, all the students I love and the alumni. Ladies and gentlemen, first of all, I have to say again, good morning and thank you for your joining in this Zoom event. Let's take a moment. Please pay your attention to pray for Sister Anistiawati. May her soul be blessed by the side of the Almighty God, Allah Subhanahu wa Ta'ala. Today, from the Master of Health Promotion at the Faculty of Public Health, present a seminar series on culture and behavior related to maternal and child health and the implication for health promotion strategies. Yeah. Ladies and gentlemen, this event was held in collaboration with all lecturers and employees of the Health Promotion Master Degree Program within the Faculty of Public Health by inviting speakers, namely Assistant Professor Muhammad Shah Jahanmiah, PhD, from the Department of Anthropology, Shah Jalal, University of Science and Technology, Bangladesh. This activity is based on the condition of maternal and child health, especially regarding to the problem of poor maternal and infant mortality rates, which are assessed based on community culture and behavior, so that we can design effective and efficient health promotion strategies, including effort related to CIA, communication, information, and education, community empowerment, networking, and advocacy. Yeah, ladies and gentlemen, welcome to the seminar series this morning. We hope that all of us can follow the event to the end, together with Assistant Professor Muhammad Shah Jahanmiah, PhD. Once again, we don't forget to say a big thank you to the Dean of the Faculty of Public Health, the entire committee of fellow lecturers and students, not forgetting to the Assistant Professor Muhammad Shah Jahanmiah, PhD, who was pleased to be a resource person in the seminar for today. Likewise, to friends who have worked hard and courage behind the scenes, who have devoted their energy and time to this event. Also, Ms. Ratih Indraswari as a moderator, who will oversee our seminar series. Thank you very much. Representing the institution on behalf of the Dean of Faculty of Public Health, I open this seminar series by saying Bismillahirrahmanirrahim. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Syamsul. All right, ladies and gentlemen, the next agenda is the main agenda that we are waiting for. We have a speaker that has already with us. I'd like to greet Assistant Professor MD Sajahan Mia, PhD. Hello, Dr. Mia.
Assalamualaikum. Hello, everyone.
Waalaikumsalam warahmatullahi wabarakatuh. Well, Dr. Mia, do I correctly pronounce your name?
MD Shah Jahan Mia. MD for Muhammad. Shah Jahan Mia.
Muhammad Shah Jahan Mia. Okay,
Yes.
Thank you so much. Okay, and now until the next 1.5 hours, we're going to start discussion about social and cultural influences on maternal and child health and its implication for health promotion strategies. Dr. Mia will present his topic for around 45 minutes. And after that, we will have a discussion for about 45 minutes as well. And for your information, Dr. Mia, our audience is students, mostly from Master Program of Health Promotion. And for all the audience, you can ask a question or some questions, it's okay. So if you have a question, you can type your question in the chat box during the session, or you can ask the question directly to Dr. Mia after his presentation by raising your virtual hand. Okay, Dr. Mia, I will read your profile first. Please correct me if I'm wrong. Mr. MD Sejahan Mia has been working as an assistant professor in Department of Anthropology, Shah Jalal University of Science and Technology, Bangladesh. He has finished PhD in Health Social Sciences under the Department of Society and Health, Faculty of Social Sciences and Humanities, Mahidol University, Thailand. He has so far published quite a few articles in reputed national as well as international journals. He has successfully accomplished some research projects sponsored by A2I, Access of Information, of Bangladesh government, Shah Jalal University Research Center of Shah Jalal of Science and Technology, Bangladesh. And he has also presented research papers in a few national and international conferences. All right, Dr. Mia, now it is your time to present your work, your paper. You have 45 minutes, so please.
Okay, thank you so much, Rati, for your nice introducing. And Assalamualaikum everyone. I am really honored and feel happy to be here this platform to share some experiences about the maternal and child health in context of Bangladesh. Thank you for inviting me in this program, especially to my friend who just passed away this morning, Annie Situati. And as a professor, Dr. Jaru, she contacted with me by email, and the dean, Professor Shamsul Huda, and all the participants. Thank you so much, and welcome to my presentation. Today, I will just share some experiences about, because you all know better than me about health promotion and public health. My background is not public health, and that's why I have some work, very little work on maternal health and qualitative mostly in context of Bangladesh, and it's focused on the medical anthropology. So may I start now?
Yes, sure.
Okay, I'll share my slides here. Can you see my slides?
Yes, I can see it clearly.
Okay. Today's the title, and here this title is some difference, because I got this when I got the invitation. That time the topic was given me in this way: the social and cultural influences on maternal and child health and its implication for health promotion strategies. Thank you to the Faculty of Public Health, University of Diponegoro, and the participants again. And today, this is outlines of my slides. I will share very shortly on health promotion, because you know much better than me. Yes, I will just information share very simple way, and the main focus is why socio-cultural influence is important. This is my part, because the anthropological issue, the cultural, social, behavioral part, mostly focus here. Then whose health, is it maternal, child, adolescent, or more, which one we can go for, or women's health, we discuss here. Then I divided into my presentation on the maternal child health is here. Three part is ANC, delivery, and postnatal care. Although there are some other birth planning, then birth spacing, postpartum contraception, other things, but we'll focus on these three part in context of Bangladesh. And I found some articles in Indonesian context, especially your Siaga, the Siaga campaign, and another Indonesian elite Febriati, she did work on spousal relationship. In that context, the health promotion, I will share that one, and health promotion context specific strategies. Just one example. The overview of health promotion here, the definition, health promotion glossary 1990, they define health promotion is the process of enabling people to increase control over and to improve their health. And here you find different approaches, models are there, but I'm showing here two approaches here: social and behavioral approach, biomedical approach. But this biomedical approach is not focused here, studied. And the different models also, especially 5 models are working, but I will not go for that one. The social and behavioral approach context, I will this lecture will content. And the issue when we go for the socio-cultural context for health promotion for the maternal child health, there might be focus on the prevention, like disease-based issue, different stages, and then go for intervention like information, communication, management, and control, and how we provide this intervention, like the promotion process might be digital way or the manual way. We can go for documentary, advertisement, or for the postering, billboard this way. The focus on the promotion, why? For better health. The special focus is the right information for the right person. This is the main socio-cultural context. We can provide the information. If the person is not the right or appropriate, the information will not work for the, or the intervention might be failed. And there are some health information practice like this choosing healthy food options, engaging in regular physical activity, participating in health promotion and education programs, and accessing preventive health services like cancer screening. The reason why why there might be the program fail, there's possibility, or the difficulty maybe because of the mismatch between the individuals and the program priorities. When the program person or say provider, they did not consider the individual or context, people, place, or context, the program priority might not meet the achievement or target. And health, because their health service providers emphasis on long-term benefits of behavior change, whereas the participants might maybe more the focused on their present personal cost of such changes. Now, the why social and cultural influence is important. In anthropology, we always focus that every behavior is context specific. How the beliefs, perception, and practice related to maternal and child events are highly embedded in the specific context of a society. The concepts of motherhood and maternal illness are viewed and explained differently in different societies. Like in the motherhood, if in context of Bangladesh, if some women fail to give birth, there are many stigma, socially stigmatized. She have no recognition about them as a woman in Bangladesh, but maybe in other country, not same. The meaning would be different, and maternal illness is also different, can be viewed differently. Like in Bangladesh context, when you'll find many articles that someone got conception, the husband or family member will introduce herself that, oh, my wife is sick. That means she got sick or she ill. It's not. It's the normal situation. Should be normal. That's why I am saying that it's differently in different societies. In how can we define this illness? Or in medical anthropology, there are 3 terms that illness is the individual feeling, individual identity, what she or he want, say that is he feel unwell, and the disease might be the doctor's perspective, and the sickness is societal perspective. So how these illness, sickness, and disease are constructed in the social process. So, and the meaning also constructed in context specific way. The symptoms, pains, weakness considered as being sick are shaped by cultural and moral values that I just shared and experienced through the interaction with members of one's immediate social circle and visit to healthcare professionals and influenced by beliefs about health and illness. This I divided this health-seeking behavior in, it's not you will find the reference also. According to this reference, they divided that these 5 layers of health-seeking behavior is like individual, how the meaning constructed in individual level, their personal beliefs, attitudes, behavior, and knowledge. Interpersonal or social level, the closest social circle of the individual, such as family, friends, and their networks. Community deals with the social relationships, such as school, workplace, and neighborhoods. And the society explains aspects the cultural values and public policies, laws, and regulation, resource allocations, and the global aspects, including the human rights, healthcare coverage, and multinational corporate marketing way. This way, the meaning creating or constructing for health-seeking behavior in every aspects, like not only for maternal child health, in every aspects of the health issues. And horse health, when we are saying that maternal and child health, do we just confine it in maternal and child health? Because health, when we are teaching for the women or girl in school level, it's sexual and reproductive health. When she go for adolescent, it's we're calling adolescent health. And then she adolescent or early marriage is very common in developing and low income countries, like in Bangladesh is increasing trend there, because different social and cultural contexts are there, economic context. And this early adolescent, when got pregnancy, then we are going for adolescent, and this is very vast. I'm not going for that way. That's maternal health, child health, newborn health. So we are dividing in different part. But if we go for as the women health, then it would be more holistic for the health of women this way. And this, I already said that this health is this maternal and child health not only start from the conceptions before the planning, birth plan. In Bangladesh, many projects, especially BRAC, national international NGOs, are implementing this birth plan projects. They give a birth card when they are preparing, or they need to visit the physicians, and they can even visit the nurse, their NGO staffs, and counselors. So for why the economic, mental, and social, for social stability, are they are prepared? Because you will find that many abortion, the reason underlying factors are they are not prepared for the birth. When they conceive, they go for abortion. So this is not focusing in our lecture today. And then we go for the conception and ANC. The conception is this way I will discuss in later more details. Here's the visit, family members, access, availability, affordability, and communication, and the delivery decisions are these for home birth, hospital, or clinic, traditional or the TBA. Is it traditional birth attendant or trained birth attendant, or the delivery process is normal or cesarean? And the PNC part is number of visit, breastfeeding, exclusive breastfeeding, birth spacing, postpartum contraception. I will not focus on birth spacing and postpartum contraception. That's only the PNC visit and the breastfeeding issue. That's some experiences. Why this health is important? If we say that's because around 343,000 women die every year due to pregnancy-related causes that could be preventable. And the journey to become a mother have to face barriers and uncertainties of choices in reproductive technologies and information sources related to fertility, pregnancy, and the childbirth. And women lost their agency over their bodies and fertility because of the relying and dependencies on doctors' expertise, expectations, and the authoritative knowledge and medicalization of reproduction. So this way, women have lost their agency and their power over their bodies and their fertility. So this is the way the why post health maternal or child. Now I want to focus on our issue that maternal, the first stage of the ANC visits. Here, WHO recommended 4 visits to physicians, but in Bangladesh context, very few pregnant mother visits 4 times to the physicians. Though the Bangladesh maternal mortality and health survey 2016 shows that their visits are increasing 47 now in 2016, 47%. But these are not is it quality visits? We can question, because the primary care report they found, and one study found that the NGO staff, the nurse, and the community clinic, when they are visiting to the mother, they just go for the blood pressure, height, weight, these issues. Not they have no, even in the community clinic there is no ultrasound machines and other equipments. So how these visits are quality issue. And the visit depends not only the pregnant mother or the spouse, but also the family member, access, availability, affordability, and communication. And in context of when I will go for this diagram, then I will show this issue more details. There's like family member. In one study, they found that the mother-in-law saying her son's wife, the pregnant mother, that I gave birth 10 children without visiting any physician or hospital facility centers in home. So if I can do that, so why you need to go the hospital or to the physicians? This is the cruel reality in context of Bangladesh. So these visits and the visits government also showing, but there are also inequality about the number of visiting. There are like 31.2% of the women from the poorest wealth quintile receive ANC from a medically trained provider, in compared to with the 81.9% women from the richest quintile. And this number of visits more unequal in context of the capital city, Dhaka. Like in slum, 42% still in 2017 findings, this still 82% of the delivery workers at home in the slum, and 76% of them attended unskilled or traditional birth attendant. So this is the real scenario of the ANC visits in context of Bangladesh. Here, one of my projects just finished last year, and this I just dropped my manuscript, and from that manuscript I sharing this this diagram, and I did not insert it here the quotation because I'll submit soon. Here the reality of the findings of the health information message in context in the tea garden area, tea workers and the urban compare it was comparative study, the tea garden worker and the urban mothers. So how they have access to the health information message, and they can go for or reply or response to that message. Mother, one project is Mama project. if someone got conception, she can register over phone and she will get the she will receive the message from the Mama Project Authority or project people when she need to go for the visits for ANC, what kind of food she need, what kind of physical activity or other activities can do, or food behavior they provide via the SMS text. But in context of the tea garden worker, they have no access to the device. It's like here we can see the individual factor here, personal attitude. In urban context, majority of the mothers shift to their mother house. Still, one study findings in 2021, they identified that majority of the mother, and in our study also, that urban mother, they feel comfort to move their mother's house rather than staying the husband's house. So when they are shifting, how they are maintaining or ensuring their ANC, their food intake timing, and majority of the mother in the tea garden worker, they cannot maintain the timing because they have to hard work and they got very low paid. And the household and physical activity, they have to involve many, and this is also the social issues, because if the mother do not work properly, she is not being a good mother or wife in the family, and the access to the device, information and decision as well. So women cannot access, and many tea garden workers, they have no device for that. And although some of the most of the urban mothers, pregnant mother, have the devices, but they cannot, they got the information text, but they have no cannot decide alone, or the other network of family members to go for the visits to the facility center. And for the economic factors, their financial stability, I already said that tea garden for quintile, they cannot go for that. They cannot arrange the quality of food. They just take the dry food because they got very low paid. It's around less than $2 every day, the tea garden workers. So you can just imagine how they maintain their family. And visiting place, they can for treatment, they cannot go for the transport and cost as well. And cultural factor here, the food taboos, many is strongly maintained, even not only for the tea garden worker, it's also for the educated and urban mother. Many mother-in-law, they ensure they cannot do it, they cannot go outside in the evening, they cannot eat the many fishes like the boa local here, the mouth of the fish is large. They believe that, oh, if she feed this fish, the newborn mouth size would be like that. And if some of the meat like beef, there are some possibilities of allergy. So this kind of food taboos are strongly there. And many mothers, especially for the tea garden workers, the rural mother, they believe that if they intake good food, then there is a possibility of chance to the newborn, the large size, that would be the painful or the tough for delivery if they go for normal delivery. So these kind of reality are cultural factors, and the societal factors also, the food intake, decision maker and positions, types of delivery. They go for the normal delivery or the hospital-based facility delivery because there are some religious issue. The female pregnant mothers do not want to go for, or the family members don't want to go for, if the male doctors, their the religious issues and the decision-making process, not only for the husband or the mother, there's the family member decided these issues. And the environmental factors are the seasonal context, especially for the tea garden workers. In the rainy season, they cannot go outside because the slippery, muddy pathway still not the road is constructed with a concrete, and health service in a health institution also, because in one study, the BMMS, Bangladesh Mortality and Maternal Mortality and Health Survey 2016, that they ensure that the Upazila Health Complex, the sub-district, Upazila means sub-district administrative zone in Bangladesh, sub-district hospitals, they have only capacity to provide 30% health services for the pregnant mother. Then how this ensure the health services for the mother? And health institutions, like their cooperation also here work, because as they are limited services and the number of patients are high, so their quality, they are non-cooperative. The nurse and the attendant and the physician are quite busy, and they have study findings that they non-cooperate, and the challenge is to take decisions also, that how they will go for the health services. So this is for the ANC issues. And the delivery issue, we can this is I also share that you know better about the health promotion. I'm just sharing the challenges, issues, experiences in context of Bangladesh here. The delivery, when we think this two issues, cesarean or normal. Cesarean versus normal here, the very lowly considered the planned cesarean section, considering the complexities of delivery, they are unplanned. If you go to the hospital or clinic, they will go for cesarean section because they are clinical, or clinic manager or the authority have a profit issue, the physician also, the SARS. And so this issue, people do not misconception about the cesarean sections. And another misconception about visiting facility center or hospital, they are brutal. The physician and the hospital authority are brutal. They charge a lot. And if I go for hospital, they will go for the cesarean section. And the religious issue, I would say, that's really a male doctor, that cost, high cost, communication. And if the cesarean section, the newborn would be less preventive capacities. The newborn have low capacity for the preventive internal immune system, low immune system, and their lack of facility services like infrastructure, workforce, and facilities cooperation. And for the home birth, this really risks for both mother and the children. And there is still, although government training the local birth attendant, traditional birth attendant trained, but still they are TBA is TBA, because these trained birth attendants are not trained, because they did not, although they are trained, if they find some danger sign of the mother, they must refer to the health facility center. But this TBA study findings reported that this traditional birth attendant or trained birth attendant did not refer to the hospital, because they feel that if they refer to the facility center in case of danger, this is their reputation issue, though this birth attendant is not trained enough, or we should not go for this birth attendant. So that's why they take the risk for taking mother for the home birth. And the popular discourse about cesarean delivery in context of Bangladesh is one study I found, and there that if someone go for normal delivery, she's traditional mother, and someone go for cesarean, she's modern mother. So it's popular discourse are established in context of Bangladesh. And the cesarean delivery is painless than the normal delivery, painful. So, and if the cesarean baby would be the intellectual, but in compared to their less intellectual for the normal delivery. And most of the physician and the community perception that if someone got first time C-section, then she had no choice for second time for the normal delivery. Although in other countries context and study, they're very common, so second time normal delivery. But if you in context of Bangladesh, if you go for the physician will ask the first one is C-section. Yes, then you have no choice. If you want to wait for the normal delivery, the risk is yours. The mother and the newborn, the risk is yours, family member or husband. So then the parents did not go for take the risks. And service provider preference, because the physician preferred there is profit and or the charge and the profit of the facility center. C-section charge, fear, risk of both mother and child, and family pressure. Like in one study in our health information study, we found one quotation that the mothers, parents-in-law, and even husband do not wait for the normal delivery if they know early or by the ultrasound that they are going to be father of a son, is gender preference son. They do not want to take the risk in compared with the girl when they know. So this is the real scenario about the cesarean sections. And now we'll turn to the postnatal care. Although they are WHO says 2 visits must, but who are the influencing decision makers? If they go for the facility center, they got the auto postnatal care because they stay 4, 5, even 7 days. The facility center or the physician takes sometimes even to the 7 days for maximizing their charge. And so, but the normal delivery, they very rare found they go for the postnatal care visit that by the 2 weeks. Even for the cesarean, if they come back 2 or 3 days or 7 days, they very chance or very low study findings. They go for the visit to the doctor. And even for the newborn, when they're in the home delivery in context of Bangladesh, the parent-in-law, there is strict rules still there. The newborn should be the bath shower because there's some white part like rash body. This is profane, not sacred. Is profane. So it should be she has to bath or shower the newborn. So this in context hospital there. Some we know that the medical, you know better that the drying wrapping method they are in hospital, but in home birth you'll very rare case. You know that the pneumonia is the major cause of the child death, child mortality. So this is the scenario of the PNC in context of Bangladesh, and they also go for the cutting their hair of the newborn in the same day after just immediate of the delivery. So this is the reality. And if we get a large number of women in South Asia have the little agencies in deciding. We already discussed their health service. They cannot go for the PNC. And in Bangladesh, UN Women Report 2014, they found that 37% of the women find difficulties to make decisions on their own in case of health disharmony or care services. So you can think the PNC about how they can or not. And the newborns who had received at least for the in newborns care, there's 3 components. Those who visits studies findings that 56% less likely to die during the first 7 days of their lives. But in a majority of the but still in Bangladesh, like 43% are in home birth. So how can you can consider imagine about the newborns visit, like for now for the PNC here, that's child health. Uh, I will focus on the I question. Okay, the I will focus on the breastfeeding, exclusive breastfeeding. In the global breastfeeding scorecard, only 23 countries out of the 194 countries have exclusive breastfeeding rates above 60%. And Sri Lanka is the highest one, 75.8%, and the lowest in Pakistan, 37.7%. And in Bangladesh, it is only 55%. What are the barriers for the exclusive breastfeeding? In Uddin ETL 2020. Just last week, these study findings published in the BMC in the context of Bangladesh. I referred in the next slide. So this study, according to this study findings, that individual factor, what the misconception about breastfeeding. Most of the mother, and not only mother, there even parents-in-law also misconcept about the breastfeeding. Like one mother said that I did not provide colostrums to my child as I thought feeding colostrum might cause loose motion. So think about that. They think that loose motion, as it is very thick, and the newborn infants are unable to digest it. Therefore, I gave honey to my child. So this is common. Honey and sugar water is very common, and lack of knowledge and skills among family members and mothers. And this one quotation from this: a mother breastfeed her child immediately after feeding the complementary food when she lies down on the bed and talking to the father of the child. In this condition, the child discontinued taking breast milk after feeding to 3 minutes. Then the child started crying, and the mother gave chocolate to the child to stop crying. So how they are feeding, just imagine about this. And similarly, one mother said, I was supposed to provide sugar mixed water to my newborn baby as per the instruction from my mother-in-law, but I did not know the benefits of giving this sugar water. For society level barriers, there are some socio-cultural norms, beliefs, and practices hinder the breastfeeding. My mother-in-law instructed me, one mother shared that, provide formula milk to my child when I became busy for cooking meals, because their mothers have to be a good mother, good wife in the family. So they have to be busy in other stuff, family responsibilities. Other household members, for other household members, she busy for cooking. My mother-in-law thought if I breastfeed my child, he or she could take much time, resulting in disruption of cooking meals in time. Therefore, to satisfy her, I provided formula milk to my child. So for other work, they have to go for the formula food in place of, instead of the breastfeeding. And another one is the mother of my grandson often provides semolina instead of breastfeeding because of her lack time. She is mainly responsible for doing household chores, as she is the young energetic women in the family. So think about the mother have to involve in other family tasks in less emphasizing the breastfeeding practices. And the system level barriers are there: adverse effects of cesarean delivery of breastfeeding, like when someone go for cesarean, they have some complicacy. They have to intake the antibiotics and other medicines. So there are some misconceptions about the breastfeeding. If they breastfeed their kids, their infants might be got the medicines from or painkillers, other kinds of their medicine reaction to the newborn. So like one mother says, I had been suffering for the last few days from an infection in my surgical incision mark immediately after my cesarean delivery in a low cost facility. At that time, I had no appetite for food due to taking a high power antibiotic for a long time. So I was unable to produce breast milk sufficiently, and I initiated formula milk as a substitute for breast milk. However, after the improvement of my illness, I was still unable to breastfeed sufficiently. In the meantime, the child was habituated to formula milk. Another one is attractive media advertisement to initiate breast milk substitute. You see the media, especially television, Facebook, and others. The formula milk advertisement. Mothers, oh, if you go for Horlicks or other kind of this, uh, your kids will get the all kinds of vitamins, minerals, and other things. So the mother and the other family member influenced by this attractive media representatives. Like one mother once said that since I thought that I was unable to produce sufficient breast milk to feed my child, I went to the physician and requested him to write the name of formula milk. I learned about feeding formula milk from watching television, but I was unaware which one is best for child health. Then the physician prescribed the name of formula milk. Thus, I started feeding formula milk at 4 months of child age. And another barrier is the inadequate facilities and support process in mothers work environment. Like in when you go for bus or train station or even in facility center, even in my university, you will not find any breastfeeding corner in the and for you'll go for the bus station or train station, you'll not find this way. Although some NGOs are now working and advocacy for establishing this, but still very low. One said, I live in a nuclear family where no one is available to look after my child. In this situation, I am not allowed to work as a maid servant in others' household. If I want to carry and keep my child with me, meanwhile, I have lost a few job opportunities because of the situation, but I desperately needed a job to survive. So this one is Uddin, Fakhruddin ETL. You will find 2012 in BMC. In context of Bangladesh, the maternal, just very brief. One of the renowned professor, Dr. Fozia Hussain, is the medical university, Bangabandhu Sheikh Mujibur Rahman Medical University, shared that we have lost the art of normal delivery science. In context of now, the Stop Caesarean Section campaign started against this caesarean delivery. So you think when someone go for physician or they have to go for the caesarean, normal delivery is very unimaginable in context of the facility center. Although 2 or 3 medical hospital privately, they go for packages for the delivery. Either he or the mother give birth to normal or cesarean, their charge is fixed around 50,000 Bangladeshi taka. These hospital many are going to preferring for this for their give birth. Other the private clinic, especially for the poor or the marginalized people, when they come to the urban or they go for the private clinic, they have no choice or options except the cesarean sections. So this is that's why she said that we have lost the art of the normal delivery sciences. And the maternal mortality in contrast to Bangladesh, the mortality rate decrease is noticeably from 574 to 194 per thousand live birth in the year of 1990, 574, and now in 2010 it was 194. But in Bangladesh maternal mortality and health survey 2016 found that 196 per 10,000 per thousand live births. And increased skill delivery attendance from 5% 99 to 32% in 2011, and birth in health facility center also increased the 23% in 2000 to 47% in 2016. And WHO refers although that the cesarean section should be 10 to 15%, considering the complexities of the mother for life-saving purpose. But in Bangladesh, you will find it is 23% in 2014, and 2019 report is 51%, is increasing, it's alarmingly. And it was also reported that 80% of all deliveries in profit-driven facility center or cesarean section, and the rate was highest among the risk families. And the compared with, if you consider the European context, like in Sweden, there are only four cesarean section per 100,000 delivery, and 18% C-section, and 7 in Netherlands. With the C-section rate is only 14%. So that you can see the European context and the Bangladesh context and South Asian context is also. And the clinic manager, why this happening? The clinic manager and as well as the physicians demotivated. They are go for only profit driving, and they also motivate the mothers. So if you go for normal delivery, you have to tolerate the unlimited pain, and you have risk for the mother and the kids. And when someone for the last stage visit to the hospital, the physician or the clinic authority, they suggest that you have to take the risk if you do not go for the cesarean section. There's some watering, different kind of realities are there. That was the Bangladesh context, and it's very little. Just a briefing. So I should not go for this, but I'm from my curiosity, and I reviewed these 3 articles. Here I found that Indonesian maternal mortality remained high, like about 359% per 100,000 mother died from complication that such as 30.3% for bleeding, and hypertensive disorder is 27.1%. Which are actually preventable and treatable, and is also avoidable. And 10 to 15% of the pregnant and postpartum women experiences depression. Women experiences when their postpartum women have experiences depression. Your SIAGA campaign, and not only SIAGA campaign, before study also proved that the women experience a positive, stable, and secure relationship with her spouse, have better able to cope with the stress and adopt positive health practices to improve her well-being. And from what kind of support, they can go for the instrumental support, emotional support, and the informational, like advice. Emotional means so they take care. Information, instrumental means visiting or visiting to the hospital, or presenting in ANC, PNC. And the study this year published in Indonesian context, spousal relationship, says publications, they also proved in context of Indonesia that positive spousal relationship, degree of the husband's involvement in pregnancy and childbirth determines the healthy maternal behavior and well-being that reduce the distress, especially the postpartum distress. So this is the reality of the Indonesian context. So as this is the health promotion strategy, the maternal and sociocultural and behavioral context. So here, if you just very briefly, maybe surface level, I'm not sure this would be working or not, but I can share this might be context. The health promotion strategies should be context specific strategies, because you have to consider the social, cultural, and behavioral context of the target people, of the problems, issues, and the program. So when you are going to design a health promotion strategies or interventions, so you have to consider the socio cultural and behavioral part. And there's also 4 levels: individual, organizational, social, and environmental factors, or levels you might address or consider if you design the sustainable health promotion. Because if you design the promotion strategies and the community did not respond and accept, that would not be sustained. So the health promotion strategies must be proactive, accepted, and responsive by the target people. Because we found that many strategies, like top to bottom, bottom to top, there are many strategies, but their strategies should be the participatory way. The community engagement would be the best way to fit or identify these issues, how they can control, or they can able to follow that behavior for promoting their health. Like here, I put some photos, like for the delivery, giving birth delivery. There number of positions there. You will find that more than 16 number of positions for giving the birth. So, like in African context, they give birth by standing way. Someone who are immigrant in USA, the hospital, like you, the 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 I forget the name of the renowned medical anthropologist who work in Haiti. He found that most of the African pregnant mother faced problem in during their giving birth in children in USA, in the hospitals, because of the positions. Then he visited to the Africa and found their local positions, and they promote it in context of the US hospital. So they promoted this behavior and for the healthy giving birth. So this is very short and very maybe I'm not good presenter. Please forgive me if I made any mistake, and I will try to answer in context of Bangladesh if you have any questions. So thank you everyone for patience and listening me. Thank you so much.
Okay, thank you so much, Dr. Shahjahan. We got a new insight from your perspective. I see there are some similarities and differences between what happened in Bangladesh and in Indonesia. Okay, moving to the next session is discussion. So for the audience who have already the question, you can raise your hand to ask directly to Dr. Shahjahan, please. Is there anyone? Or maybe I will read some question that has audience wrote in chat box. There are some questions. Okay, the first question is from Imrul Hassan. Dr. Shahjahan, what is the perspective of long-term benefits on the health promotion platforms? Is it sustainable behavior change where a group of people realize their needs for health service opportunities? or can we call it community mobilization?
Thank you, Rati. I am Imrul from Bangladesh. I'm the ex-colleague of Dr. Shahjahan Mia. He is my ex-colleague in ICDDRB. Now I'm work for Save the Children International as a manager M&A signature program, Mamuni MNCSP project. You know that we work for maternal and neonatal health system strengthening in Bangladesh. I want to ask Shahjahan Bhai, please can you clear the concept of what I am writing chat boxes? What do you mean by long-term benefits on the health promotion platform? If you say to me, please.
Okay. Thank you, Imrul, for your questions. And here, in context of Bangladesh, you also wrote the BDHS 2014 that the every is increasing every single health service. You know that even
Yes.
not only for health indicators and even in for GDP, now government are showing that the population is decreasing now. You know the last the population survey is now 160 million. So last 4 years ago, that was 170 million. I think there's this kind of survey, I'm not sure, but the quality of the services. When you are saying that the number of services are increasing, like GDP, this the quality of the service are really controversial, because I said that in case of the BRAC, and you said the children as well, you have many intervention. When your nurse or the trained birth attender attending into the for the ANC, how much quality ANC they can, rather than the physician visiting to the physician. So if we go for this for the promoting, they are visiting to the physicians the at least four times. That if that promotion, if they are change their behavior, not only for the mother and husband, including their parents in law and other family members, and they aware, if they aware, they go for, and they start, if they start for this practicing this way, this will really bring the long-term positive health outcomes for the maternal well-being as well, because the mother is not only for this health or quality health service, not only for the mother, because of the newborn, who is the future leader or the generation of our population. That is why, for if you consider or think about the long-term care, you must prioritize this mother care, maternal health care. Can I?
Thank you, Shahjahan Bhai. I have an remain on things based on your statement. We know that our country context, community people much more aware about than previous 10 or 15, 5 years. So thank you for your statement. And we have an updated BDSS survey report, which was called 2017 and 18. Community level and facility level, both are contributed strong service for increasing the maternal and neonatal health, as NC, PNC, facility delivery, cesarean section, everything. So thank you, Shahjahan Bhai. I have another questions for you. I heard earlier presentation, Indonesia have a significant cause of maternal death, postpartum depression. In our country context, we hear again and again 5 things, as postpartum hemorrhage, eclampsia, preeclampsia, early marriage, early concept pregnancy, such type of huge significant root cause of maternal death in our country context. But postpartum depression, we heard very rarely. I want to know the root cause of postpartum depression in context of maternal death. You or Rati will answer this context. Anyone?
Thank you, Imrul. You said the BDSS 2017 is increasing. Yes, I mentioned in context of Bangladesh, there the visiting services that are increasing. But if you go for the quality, my question is still there are some superstitions, the taboos, and other things are still working in the family level. Is based on the study and recent last year studies. Maybe some in context, it's in context of Dhaka. Even in Dhaka, I mentioned in the slum, there are also difference, inequality. So that issues and postpartum depression and your questions put out in context of Indonesia. I'm not sure about. I mean, I don't know. I just found that article in their background information. Then I go for that article. That's why I mentioned this issue, because their campaign, Siaga campaign, the spousal relationships and the presence with the pregnant mother to the facility center, and that I find interesting. And you, as you are involving in Save the Children International and as a manager, and you can adopt this kind of campaign in context of Bangladesh, because you find there are some also like taboos. If husband is visiting with the wife to the physician for the NC or other NC care, still there are some social taboos or superstition working. Although you will find that in educated and urban context is different, but in context of rural, there are some also still barriers for this. So if we can ensure the spousal harmony relation and to be present in the visits and to the giving birth period, the husband or the mother can feel that three: instrumental, informational, and emotional attachment, and she can make more confident, and the mother health well-being would be more sustained. I think I guess that. And sorry, Rati can answer. I'm not sure the reason, underlying factors in the context of Indonesia.
Okay, thank you, Dr. Shah Jahan. I think there is something similar about in Japanese people actually with the Bangladesh, like you said. I think is it related with the question from Miss Novia. It's about mother-in-law. Oh, this is. I will read it for you first. Thank you very much for the knowledge, Dr. Shah Jahan. This is very interesting. I do agree so much that every behavior is context specific. In some parts of Indonesia, mother-in-law's opinion are strongest than that. It somehow often lead to unsafe behavior for pregnant mothers and also for newborn babies. Mrs. Novia want to know what about in Bangladesh? Does mother-in-law's opinion also plays a very important role? And I noticed that many times also in your presentation that mother-in-law has too much interfere for pregnant women, maybe because they live together in a house. But I also like to know what about husband or her spouse reaction? Does husband have no power or have like knowledge about maternal health? What husband do during the maternity? I think I'd like to compare this first.
Okay, thank you so much. Because of the structure of the society in context of Bangladesh, this society is still the dominant patriarchal society. Patriarchy is strongly working here. So that kind of social structure still the combined family, although now changed in context of urban, there are some nuclear family, some, not some, many more, but the control of the family is still the parents-in-law, because they are experienced one about the pregnancy, motherhood, or giving birth. When you say that, I mentioned one quotation, not in the slides, from a health information message, that one mother was saying when it was in urban context, that she want to visit to the hospital because she had the message, but she cannot, because the mother-in-law was saying that I gave but 10 children and without visiting to the hospital, so why you need to go? And so this kind of reality are in combined family, the control is still in the parents-in-laws, and the mother-in-law is the control knob of the family for taking this kind of decision. And another one is the husband. You will rare find the husband are presenting in delivery case or visiting to the hospital. Although in working, those who are living in urban or service oriented, they have to visit to without. But in other contexts, still the other family members are the decision maker for seeking behavior, fooding, what kind of food she can take or not. Is still decided by the family members, especially by the mother-in-law. That's why I found another Chaudhary ETL. You will find that I did not mention that article reference here. It's ASEAN, Mahidol University ASEAN Journal. This 2021 December issue. You will find that article shared that why pregnant mothers are preferring to shifting their mother-in-laws. It means mother's mother house, not husband's husband's house. So because she is not feeling comfortable here. So that study identified this kind of reality, because when she want to take desiring to eat something, she cannot, because mother-in-law are controlling that food behavior, or to visiting the hospital or others. And even to the I want to telling in the child health, because of the many cause of the child mortality still goes for the mother, not for the PNC, not visiting to the PNC or other health seeking, because the blame goes to the mother, that say, oh, this mother is not a good mother, she cut the fish throat and she pieces the fish or the chicken, or she go outside in the evening like Maghrib prayer, in that time, this time is not good, so she walked in the outside opening her hair. So these kind of taboos or reality are still there in Bangladesh society. That's why mother-in-laws still, although it's changing, but maybe take time.
Is it like cultural norms in Bangladesh that a woman that have been married, so she has to move to her husband's house, or?
No, it's not. It's not norms, but it's preference, because of that reality. Maybe I say so. Maybe that is because mothers are not like in what Imrul says, that 10 to 15 years back, mothers are not like want to control that way by the mother-in-law. That's why they prefer, if they visit to her mother, maybe she claimed, or she can ask to her mother, so okay, I want this, I want to do this. That's why that study, according to that study findings, I'm saying that shifting is norms, but it's very common now.
Okay, common norms. Okay, and what about government has do with this situation? Is there any effort that government has done?
Truly, I don't know about this kind of any initiative policy government has or not, because according government for the is like small country, large population. It's very small country, it's very large population. So the facility center they cannot maintain. That's like I said, the sub-district level hospital, they have only 30% capacity to provide the health services. And when I work my PhD in the workforce shortage is more than 40% per 10,000 population, like gap workforce shortage. Physician is ratio is maybe is I'm not sure the data, but it's according to WHO, the physician is WHO standard is more than triple times pressure on the physician. Every 10,000 population, maybe I'm not sure 16% something, 16 is to some I'm not sure. So it's a huge pressure to the government health facilities, because in like Indonesia, Thailand, you have the health insurance package, but in Bangladesh is the public hospital is free. You cannot just by naming the ticket of 5 taka, very simple. 5 taka is very poor. 5 to 10 taka is by take the ticket. Even in sub-district hospital, they did not take any ticket. In the medical college hospital, they have to take the ticket, and they can visit the physicians, and the physician capacity and the number of patients is too high. So that's why the quality of the service is very poor, and the policy, there are a lot of policy, but the implementation is still limitation, has limitation.
Okay. Is it the reason why majority some pregnant women in Bangladesh also attending the TBAs, unskilled worker, or maybe there are something else?
In according to the study finding, I found that the risk parents or the family member, they have a higher number of cesarean sections, but the poor, because there are still misconception about visiting to the hospital, that if they go for the public hospital, sub districts, or the district hospital, or the medical college hospital, there in tertiary level there are medical college hospital, and some now district level hospital are turning to the medical college hospital, so they can go for the medical college hospital, but there's according the ratio, and the ratio of physician and the patient is too much high. That's why it's mushrooming the private clinic. These physicians, you will find majority of the physician of the public hospital have share or own the private clinic. When they finish their duty by 2 p.m., they move to their private clinic or private chambers. So the poor people, when visit this private clinic or the other, they have to go for cesarean, or their according to their the clinic desire. That's why there's the charge of the physician and the hospital fee that is much more than for the poor people. That's why they have they don't want to visit to the hospital. There's also misconception that if they go for the hospital, they will go for it Caesar.
Okay, I see. Okay, I think we should next to the question from Perwita. Perwita asks you, what about the problem or gap that appears from digital health promotion in maternal community?
Digital and?
Digital health promotion in maternal community.
Honestly speaking, I have no experience about this digital health promotion strategy, because this is not my area of interest or expertise. So
if you permit me, Shajan bhai, I want to share something about digital health system and health promotion of Bangladesh in current context of public health sector. Can
Sure.
I carry on these things?
If Rati
Or from the
allow,
Okay,
I have
yeah.
no problem.
Okay. From the Save the Children International Bangladesh part, we have a flagship program, Mamuni, which I am shared earlier. We have make an intervention for DGAP, which called EMIS, Electronic Management Information System. As part of the Electronic Management Information System, we conduct a population registration survey where we used an Android application and collect 16 basic information on a household member, where all type of household member is eligible for this registration. First of all, we collect total basic information, then we connect these things, the record keeping system of DGSS as like as family welfare register. I think Shahjahan Bhai is well known about this register, FWA, family welfare assistant, who is responsible for the community level household survey. Then a family welfare assistant collect every single information about the maternal health of a eligible couple. I mean, who is eligible couple? From 15 to 49 aged women who is able to birth a baby, if I am not wrong. Then FWA complete her or his registration, and they counsel them that you may go to higher level health facility and take this service.
Imrul,
Yeah.
just they don't want to about the promotion practice. I know about that Mama project because that information message project is also from me. Just tell them what are the gap about the digital health promotion. Like in our project, that one health information message I already shared, that they have the information via the mobile phone registered. They got the text, but they cannot, for the urban mother, they cannot go for the decision. They cannot take the decision by their own. And even for the UN Women report, there are 37% women in Bangladesh, is the 47% in Nepal and India, and about 33 women cannot decide alone to visit their care. And if you say that for the rural mother, they have no access to the device, they cannot own. For the tea garden worker, they cannot. So that's why the health promotion, digital health promotion, if they cannot afford the device, mobile phone or the television, so how they will get access to the digital health promotion activities? So that is the one kind of the limitation, maybe, that in this way they can go for the like homestead garden meeting, like homestead meeting, like in the home, you know, you in your
Courtyard meeting.
courtyard meeting there. If like one I came to know from one study in ICDDRP, they are also doing this in Rajbari district, that they are ensuring all the family member, means the husband, in the adolescent girl in the family, the mother-in-law, they ensure participating in the meeting about raising the adolescent health, PNC, all these issues, birth spacing, all this. So if the mother or mother-in-law forget to take the medicine or visiting the date of the ANC, the adolescent girl can remind the mother, oh, you need to type, you have that, now you have to take that food, you have to take the medicine. So she can recall, because she need less in engagement in the household work rather than the mother and mother-in-law. So this way, and yeah, and she, if she knows, and she will be the mother in future, she also, this will be the long-term or sustainable health promotion. So this way we can for the regular or manual based health promotion, and digital health promotion, it would be also the context specific. Sorry, I'm talking. Can you please tell what is the limitation of the digital health promotion in your project? Just
Shajan bhai, we have another initiatives which called M Health, which you already described. Every single mother get a SMS from a health facility. At present time, the initiative is going as a piloting initiative. We hope that after completing the total registration system, we get a good feedback from the M Health system.
Okay. I think you there are some differences in program people and research people here, because when the program people they more focused on their number. Yeah. Imrul, I will talk to you in this issue.
Yeah.
Later. Okay, can please, Rati.
Thank you.
Thank you. Thank you very much. Thank you very much. It's so interesting. I will moving forward with the question that is come from Mr. Budi. Okay, I really like your explanation. For nowadays, we need great enthusiasm and effort to educate the younger generation, Gen Z and Gen Alpha, who are very close to digital technology compared to previous generations. Indonesia, with many ethnic groups, cultures, their condition and circumstances are very diverse. So a communication intervention strategy is needed. What are your suggestions for reducing maternal and child mortality through their target group of young people?
Thank you so much. Thank you, Mudi, for your appreciation. Here, I already just mentioning about the health information, digital health promotional activities, the health information message over phone. Here, there the education, the one project, they are health promotion activities. They are engaging the full all package of the family members, because if anyone is missing, don't know about the information about the promotion or health promotion, so there might be gap. Like that promotion projects, they ensuring the adolescent, as you mentioned, the younger. This is not only for adolescent girl, it should be the younger, all the younger family member of the family, because they have, yes, they have in Bangladesh as well, they have the device also, and they are well oriented about this device use. Even not only for the text, they can go for the e-health, electronic health. They can go for the information search, and they can identify the issues, and they can take the suggestions to the mother or the other family members. So if we can include this young generation in our health promotion activities, that could be more sustainable, I think, for our better maternal and child health.
Okay, thank you. As long as the channel is or the method is should adjusted with the characteristic of the young people, right?
Yes.
Okay. Next question is from Yeni Tamara, but I think it's not to relate with the theme today. But I have another question from Mrs. Yani. Hear the question. Talking about the WHO standard about the minimum visit to physician of pregnant mothers, the Indonesian government has already started the minimum of 6 times visit. However, the standard of 4 times itself pretty hard to achieve. And of course, we are going to even struggling more to meet the minimum of 6 times visit of pregnant women. What is your opinion about this, and what if this standard is applied in Bangladesh?
It is really, because 4 times is still struggling. Bangladesh government health service healthcare service provider also struggling to ensuring this 4 times visit, because although the community, their health assistants and the nurse, NGO nurse, especially the BRAC and other NGOs, and different other projects like Save the Children, other projects also, their health assistants are visiting to the mother, but to meet the physician, it's really 4 times is still staggering. 6 times would be maybe burden. If they can ensure the 4 times, they can maybe consider in future, I think, because for they can provide the 6 times, but before that they have to increase the facilities. Like I told that sub-district level hospital, they can ensure only 30% of the service. So how can, if they now increase the number of visit, how can they will ensure the 6 times? So at least 4 times now, maybe it's, if they can ensure, then they can the policy people can consider, or I will include it in my study, that in Indonesian context already. I really don't know the 6 times. So I will in policy recommendation, I will include it in my studies when I will write the policy recommendation. Government policy makers can consider this, the 4 times to 6 times.
Okay, tell us the result then.
Okay.
Okay. Next, is there anyone who would like to ask again to Dr. Shahjahan? You may raise your hand, please. Is there any question? Dr. Shamsul, do you want to ask? Hello, no one? Okay, I think there is no more question. Really? Are you sure?
Okay. So maybe I cannot make understandable or interesting, make this issue more interesting. Here,
No.
Imrul Hassan has text here one thing: the Adolescent Health Club. He maybe is important platform for disseminating information to prevent maternal and neonatal deaths. So maybe that would be the another option. Adolescent Health Club would be, because the both girl and boys, if they know information, they can be more aware, because still in our generation, still husband feeling stigmatized or shame to visit with his wife to the facility center. So if they know and about this caring or health facilities, this would be more sustainable for the future, because they will not feel any uneasy to visit this way, maybe. Okay.
What can you explain more about the Adolescent Health Club? What is the facilities and what the adolescent do there, or what is this?
I'm not sure. Just he mentioned Adolescent Health Club.
Oh,
maybe the Save the Children just introducing this project.
Okay.
Imrul, are you here?
Yes, brother.
Can you explain what do you do there, Adolescent Health Club?
Exactly. The Adolescent Health Club we format with few people of whose ages 13 to 19. We established the platform. Nowadays, we implement the activity in community level. They can organize after a specific duration. We sit with them and we share a few messages or BCC materials, printed BCC materials, which is carry on a defined message for maternal and neonatal health, as when a mother will come in facility and how she can receive a specific service for her pregnancy. And then after during delivery, what can she do? Then what can she do after delivery from delivery to next 14 days? such type of message we disseminate with the in community by using this club platform, and we defined a club leader who organized all people for working this activity at community level.
Okay.
Okay, thank you so much for your explanation, Mr. Imel Hasan. We also in Indonesia have namely Posyandu Remaja, Posrem. It almost similar with the Adolescent Health Club, but it's only not all districts in Indonesia have conducted this Posrem, but I think the Adolescent Health Club is similar, and we can adopt from Adolescent Health Club district. Thank you very much, Mr. Imel Hasan and Dr. Shahjahan. Okay, back to the audience. Are you really don't want to ask again? Is there anyone have a question? Okay, I think there is no more question, Dr. Shahjahan. Maybe before I go to the closing session, you can conclude the discussion today, or some closing statement maybe.
Okay. Thank you so much for giving me this platform, and I'm really honored to meet with you. And I think we can work together in future as well, and especially in health promotion. And I can talk with my department to consider you, if you agree, if your faculty or university agree to MOU with us, because in anthropology, especially the medical anthropology, has focused on health promotion, public health issues. The quality research methodology, we can work, suppose research together, then we can maybe exchange course if your program or here. Thank you so much. Thank you giving me this opportunity, and hopefully we'll meet again soon, inshallah. Assalamualaikum everyone.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Dr. Shahjahan. Okay, ladies and gentlemen, that's all for today. Thank you for your participation, and we would like to apologize for any mistake and imperfections during the seminar. I wish you all a pleasant day. Thank you so much, and see you in the future series of educational seminar. Wassalamualaikum warahmatullahi wabarakatuh. Thank you so much, Dr. Shahjahan.
Thank you so much, you all. You are welcome. Yeah.
About MOU, maybe Dr. Shamsu.
Okay, okay. I know two terms from Wati and others. Yes, the terima kasih sama-sama. I know. When we are in Mahidun, that we in that time, she also known about in Bangladeshi term. The thank you.
Oh, really?
Don't know, but yeah, it's really shocked for me, and I also pray for her. May Allah give her the highest place in Jannatul Firdaus. Okay, thank you. Yeah, yes, please.
Thank you, Mr. Shahjahan.
Yeah, you're welcome.
Next time.
Okay, thank you very much.
Thank you so much. Okay. Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.
Kumaseko.